Okay, so we're gonna go over neuro and traumatic brain injury, and then I think in here there's like a review of stroke, and I have some questions also to the side. I guess the people that went to the session yesterday already got these, but this is kind of like a bunch of review questions for the whole semester, basically. I think how many are there? Oop, there's 25. So we can go through that quickly, or I'll just give you guys, it comes with answers and everything. Maybe we can look through it. If you guys have questions on any in particular, we go over it. Um, I have a picture with the cranial nerves, and I know they went over the different types of lobes and stuff for the brain in the case study thing that you guys did, but honestly, don't worry about it. The cranial nerves, I don't think you worry about that either from memory. It's nice to know, and I think it comes up a bit for your Kaplan exam that you'll have in 242. You'll have to do another Kaplan exam, comprehensive, so you might get some questions there, but you won't really be directly tested on this. It might show up on UWorld, but it also probably won't show up on the NCLEX. So it's here because she likes it. So we'll move on from there. I kind of wrote down the overview of the meninges and the ICP. So probably the main thing to really focus on is just that, in there you have the blood supply, you have cerebrospinal fluid, um, and all of those together, make up the intracranial pressure. When one of them is out of whack, it can make um, it can give you ICP, and you can try to fix it by kind of manipulating some of the other ones in various different ways, as we'll kind of um, look at below. But that's pretty much all you gotta know, really, is that they play with each other, which kind of goes in line with this formula here. So your cerebral perfusion pressure, I put the definition down. Cerebral blood flow that brings O2 to the cerebral tissue. So that makes sense. It's the pressure, it's the amount of blood, it's vascular. So what is the normal values for the CPP? And like I said again, don't focus too hard on the anatomy part of it. It's really not. It's just not. Yeah, that's the nice thing. 60 to 100. So 60 to 100, like you mentioned, that's your normal value. What is associated with bad outcomes? Like what amount, what number? I think if you guys know those two, yeah, below 40. If you know those two things, that's you know a lot about it, and that's as much as you really need to know. Just be able to interpret. There is a formula for it, so remember they all play with each other because they're all affecting the pressure in the head. So CPP is equal to what? And it involves your map, it involves your ICP. So some values, how do you get to this number? It's going to be map minus ICP. So again, they all play with each other. So if you affect the map, you're going to affect the CPP because um, these two turn into this number. So, and then vice versa. If you affect ICP, it's going to make a change into your CPP. And, your brain doesn't have reserves of O2. Your brain doesn't have reserves of glucose. So if this pressure isn't sufficient, or even if it's too much pressure, the brain's not getting what it actually needs, which of course you can imagine is bad because you kind of need your brain. So we'll go with that. So that's important to know. Review of MAP. What is your normal value for MAP? Pretty similar. We'll say 70 to, I think she said like 110 for key, for optimal perfusion. Um, and let's say just above 65 for minimum and 70 to 110 for optimal perfusion. The semantics of it, the semantics of it doesn't particularly matter. Um, it's just you kind of know the general idea and you know how to calculate it. So again, you guys have had to do this probably for every test, or we keep bringing it up because it should be coming up probably every test is the formula for the MAP. So what is that? Yeah, so your two diastolic plus your systolic quantity over three. So if you can do that, you can find the MAP. If you can get the MAP and you have your ICP, you can figure out your CPP and determine if that's correct, if that's incorrect. But again, you're not doing like a CRNA thing or like this is just a test for nursing school, so it's not going to be insanely deep. It's just pretty surface level for now. And again, your NCLEX will also be kind of surface level. ICP, it's made up of the pressure like we talked about. You have the brain and put, how much is pushing up against it from the cerebral spinal fluid or the blood that can make the pressure in the head. What is your normal ICP value? Yeah, so we'll say less than, there we go, 10 to 15 should be good enough. When should you start treatment? Around 120 or higher. Yeah. So usually it begins at about 20 plus. And what are some things you guys can think of that can increase the ICP? So think about trauma, head trauma. That can definitely do that. Coughing, yeah. So coughing that has to do with like the vagal. So coughing bearing down. Sneezing, yeah. So sneezing could do that too. I think that kind of is part of vagal. Um, yeah, stroke. A stroke can do that for sure. What about just hydrocephalus can be a cause of that? Yeah, sure. Mass in the brain, sure. Anything, anything basic, like some basic stuff. So if somebody has issues with ICP, what are you trying to prevent or try to manage to not make it worse, essentially? So blood pressure, yeah. So let's say blood pressure MAP, sure. Anything else? Basic stuff. CSF, sure. Like we can manage that. Okay. What about if the door is open and the unit is loud and the lights are on and you're coming in and out? Stimulation in general. Yeah, so overstimulation can cause it to go up. So kind of along that same vein, what are other things that kind of go with overstimulation or things happening? Stress, yeah, stress. Stress, overstimulation. What's a common thing? Yeah, pain. Pain is a common thing. You know that we know that that makes your blood pressure go up. So again, your ICP is made up of your blood supply, cerebral spinal fluid. So anything affecting that blood pressure is going to have an impact on this ICP. So if these people are, yeah, that can sedation probably the opposite. Fever, I can see that for sure. Yeah, but we're seeing how we're thinking of stuff. There's one more that I think we'll talk more as we go down, but if you guys recall, I'm sure he mentioned this. It's CO2. So what do I mean by that? Do you guys remember when he talked about that? So with these patients, yeah, it vasodilates, which means that you have more blood flow, which is usually a good thing. But if you're having issues with ICP already and it's like a careful management, Having more blood flow puts even more pressure on the brain, which is not what you want in that scenario. Usually it's a good thing, but uh so how do we prevent CO2? There you go. Yeah, hyperventilation. So we want that patient to hyperventilate to try to get rid of CO2. So that was one of the interesting things about it. So if someone's on like on a vent or something, you can manually control that. If they have increased ICP and they're on a vent, just kind of interesting things to keep in mind. A lot of things that kind of can cause increase in ICP. Um, and I don't know if we talked about this. I don't think we did. So let's talk about what are your signs and symptoms of increased ICP that you guys can think of. Altered level of status, headache, I like that. Nausea, vomiting, yeah. Especially you'll see this a lot on like NCLEX, not NCLEX, NCLEX is pretty basic. Your U World, it'll tell you like specifically like projectile vomiting. They like saying like projectile vomiting is a common one. But these are usually like some of your yeah, potentially, yeah, your pupils might be affected. But yeah, your LOC is your first sign, yeah. So that's pretty much the key. So if you guys were able to see any of these happening, you should be thinking about potentially your ICP. Obviously these are very vague things. So it obviously is going to come with some diagnostics or some other history, but because altered level of consciousness could be hypoxia, could be hypoglycemia, could be an infection, a headache with altered level of consciousness. We talked about stroke, so like yeah, it could be increased ICP due to like a stroke happening, nausea, vomiting. That could be various different things. Projectile vomiting, even like what's it called? Increased intraocular pressure can cause some of the probably not this one as much, but like a headache, nausea, vomiting. Could if you guys recall from you guys were going over glaucoma and whatnot like a while back. Glaucoma, the open angle, closed angle glaucoma, the increased intraocular pressure can cause some of the same similar symptoms. All right, so I have this line here that you guys can fill out. In order to obtain a desirable CPP, we can adjust the MAP or the ICP. So what are some ways that we can manipulate these two values to get where we want? Stool softeners for, okay. So we can, sure, yeah, so we can do so with mannitol. That's a drainage device. So that would be a way to drain some of the cerebral spinal fluid out. Okay, I like that. So these are a lot of good like interventions, not just even medical. These are like vasopressors. Yeah. Yeah, the EVD is basically that. Um, vasopressin. So with your vasopressin, stool softeners, like yeah. So like yeah, that could be another thing. So like that would be kind of like the bagel as well. Like if there's what's the word? If you're having them be irritated, that could increase it. So like general irritation, stress irritation. And yeah, like we mentioned, stool softeners can be a good thing. These are probably a bit more direct though, so I'll kind of keep these here as like the more direct things. There are some indirect things, so I like that you guys mentioned um indirectly help manipulate. I do like that you mentioned that because it's like, yeah, that's a way to keep that down. Proper management of pain. Yes, I like it. So these are some of like the preventative things. So like prevent it from going up as opposed to like directly um doing something with it. Yeah, so Fran too, I like it. Yeah, because vomiting's naturally going to is one of your signs and symptoms, and if that's happening, that's very stressful. That's something that can make that go up. All right, so we're thinking very nice. Okay. And we'll go into more detail on some of the medications as well. For now, it's just kind of getting a general overview. So it seems like you guys have a good understanding. Yeah, like the 3% and all this other stuff. Yeah, and it comes with other other information like what you have to be aware of how the kidneys are working and it's very effective, so you have to be really careful with it. You don't just kind of slap it on and call it a day. But yeah, it seems like you guys have a good understanding of ICP, some of the things that cause it, some of the ways to manage it. Because this is still also technically like a neuro one, I think it's good to review stroke, and then we'll review stroke. We'll go over TBIs in particular, some of the minor details that are good to keep in mind, and then we'll go over general care, diagnostics, interventions, and medications in more detail. Be fast, yeah, that's going to be something that's important. Yeah, so how to detect, yeah, that's the be fast. So I'll just grab a picture because it's easier than just writing the whole thing. Be fast. So if you guys have this down, you'll be able to kind of do so. You're able to incorporate it. So people B for balance. So if they're not able to walk in a straight line or they're getting disoriented really easily. E for eyesight changes. So blurred vision, changes in their vision. Maybe one's more dilated than the other. Facial drooping, have them do a smile, have them do a frown, see how that goes, move their eyebrows up and down, arm weakness, have them stick both their arms out if one of them kind of not able to get that over, or do the finger, have them put pressure on your fingers if they're having troubles with their speech, slurred speech. And then T is for time, so time the start of the symptom of when they started feeling these symptoms, but also time to call 911. So, if you're having these symptoms, call 911. Don't just drive yourself over to the hospital and whatnot. But what is the most, so let's say you have this patient that is having all these issues, or maybe not their patient. Let's say this is happening outside of the hospital. You do the B fast and you call 911 and they get sent over to the hospital. What's the most important thing at that point? Okay, let's say ABCs. Let's do ABC, sure. It's always going to be important. ABC's your CT, yeah. So CT of the head. And what is the purpose of this? I like that Glasgow coma scale. By the way, heads up, you allegedly may or may not have to do one. Allegedly. Without the scale. Allegedly. So here's the scale. Uh Did we see? Yeah, so determine what type. So the CT of the head is there for them to be able to see if this is a hemorrhagic stroke or an ischemic or an embolic stroke. The main purpose of it is that if it's a hemorrhagic stroke, they can't use a lot of the medications. Like they can't use a lot of the treatment that they can with the ischemic stroke. So it's to determine if this is going to be an ischemic versus hemorrhagic. And let me see what else. See who else wrote stuff. Just know three are dead. Pretty close. Where are we at? Where are we at? Yeah, so differentiate. Yeah, so Kaylin asked, intubate for what GSC? Eight and less, yeah. I really like the, because it rhymes, like less than eight intubate. I like it. My favorite is still, was it 3.8? She got DKA. Or she DK8. But it didn't even I don't remember it coming up. I remember we came up with it and we were like, damn, that's crazy. But then it didn't even get tested on, so I was like, whatever, bro. But yeah, so I'll just put in just I'm not sure if they're ask a question on this or not, but um should be done within 25 minutes. Should be interpreted within another 45 minutes after. Overall, it should be around an hour total that they do the CT and then interpret it. Time is tissue, pretty much. And here's your GSC scale that allegedly, um, yeah, allegedly. Okay, I think that's everything I have for that, right? How to detect, most important thing. Oh, here it is. Possible causes. I guess we can talk about. So, I think it was listed down in there. I'm sure you guys know a lot of it, like what can cause ischemic and embolic, and yeah, hypertension can be one for both. Yeah, AFib, that's a common one. Hypertension can also cause hemorrhagic, too much pressure, burst, boom, boom, boom. Atherosclerosis, yeah. DBT. DBT not as likely because I would say, well, I mean, it has to like make it to the lungs and then get back up to the head. It's not as likely, but it can happen if you have like a clot makes its way through and then it keeps growing as after it gets through. Or what else? I do notice like he did list it. Status post surgery with DBT that evolves. But I guess the key word is that it evolves because typically it goes to the lungs first. Um, Although if there's someone with a heart defect, like they have what's the I can't remember what it's called, the one of the pediatric heart defects where they have like a hole in their heart, the clot from a DVT can skip the lungs and go straight into the head. Forgot the name of it though. Oh, what else we got? Discourse DVT. BC. BC. Before cry. I don't know what BC. BC. Birth control. Okay. Took me a second. Patent duct, something like that. Icteriosis. That sounds about right. I wouldn't know. You never know. 22-year-old. Aw. See? It's not just me. I told you it's not just me. British Columbia. Oh, actually, it was actually listed here. That's cool. Arteriovenous malformation. Cool stuff. Trauma. All right. Yeah, don't forget again. It's just there for reference and context. You're not gonna be like, what select all that apply causes of, don't worry about that. He did go into slight detail about epidural versus subdural bleeds. I think in the lecture, but it's not too important to know for this. But if you want to know about it, I will post it here. So epidural versus subdural bleeds. The main thing is your epidural are quick to happen, easy, not easy, but like more obvious. Um, it's rapid deterioration, rapid process. This one decompensates faster, but because it's more pronounced in terms of symptoms, it gets caught faster and treated faster. So ironically enough, it I think typically has better outcomes just because it gets caught faster. Your subdural, it'll be like a slow, consistent bleed. It can change obviously, but for the most part, it will be more slow and the symptoms will not be so obvious. So the subdural, even though it's a slower bleed, is caught way later and treat it way later, so it has worse outcomes because of that. And then here, like, again, don't focus too much on any specifics. It's just there for extra information. I'll signify that it's extra. Green for extra. Extra, extra. Craniotomy. I think so. Like to relieve pressure and drain some of that stuff. And probably uh like kind of caught not cauter maybe it is cauter like like the little surgery they do to kind of fix some of the the bleeding. Yeah, the clip. Okay. Oh, I forgot here. I did write down some like events after a stroke slash trauma. The main thing to keep in mind here is you have trauma, swelling of the brain or bleeding, bleeding increases ICP. You guys were talking about birth control, so I read this as breeding. Oh, well, whatever. Increases ICP. Increased ICP inhibits brain blood flow, which can cause a decreased CPP overall because if you have decreased blood flow, and remember from your formula, it's MAP minus ICP. So increased ICP leads to decreased CPP, in which case the brain is deprived of O2 or glucose. It doesn't have any reserves. So that means your brain is not getting what it needs, which means brain damage if it's not treated appropriately. Yeah, drain bramage. Even more swelling happens because your body tries to compensate. Um, it can increase your blood that increases your blood pressure because our sympathetic system is like fight or flight. We're gonna die. We need blood to the brain, increase blood pressure, constrict, which then makes swelling worse. If you're having issues with the pressure, then again, that can increase, it could just increase the pressure even more, which ironically makes things worse. So it can be kind of like when we went over like some of the vasopressors, and I think if you had a session with Miss Salazar, she might have gone over, how like sometimes decreasing the vasopressors can help to can help your blood pressure because sometimes it's so much constriction that you're not letting things come through. So sometimes decreasing the vasopressor can help to get blood flow and blood pressure up because you're decreasing all like if it's over constricted, over shunted, which is why it's important to be looking at like your hemodynamics using your specific stuff like your A-line and your Swan scans because they tell you more specific stuff rather than just like the blood pressure because the blood pressure can be vague. Okay, so moving on to TBI. The definition of TBI is it's a trauma, traumatically induced injury. And it comes with some symptoms that we talked a lot about, so I won't reinstate, but you guys already kind of know what it means to be neurologically altered or affected. So loss of memory, loss of consciousness or diminished, altered mental status, changes in your neuro, kind of similar to like what you get when you have a stroke, because the point of the stroke is that you're cutting off blood flow. So similar idea that damage leads to the brain not working properly. And some possible causes of it again, trauma based. So we'll just post it. Again, not important to know. You're not going to get asked which one of these is going to cause. That's not the main important stuff. It's just there for reference. They do go over this, but it's not too important. But I have seen questions on the UWorld about it. It's the Coop counter Coop brain injury. So essentially, you have that impact. It does the initial hit here and then everything every action has an equal and opposite reaction so it goes back and then it hits from the back. They hit it from the back. Yeah, the car accidents. Okay. I didn't say nothing. I didn't say anything. I was just describing what was happening. They hit it from the back and got the brain. I don't know what to tell you. That's kind of what happened here. They went boom boom. Okay. I have another picture. So with the basilar skull fracture, again, the only thing you really have to keep in mind here is with these things, you have the raccoon eyes. You have the battle sign, which is, I think sometimes I've seen it described as like a green kind of bruise in the back of the ear. And the raccoon eyes is exactly kind of what it looks like. It kind of looks like discoloration, like a black eye kind of looking thing. You also have like the potential of losing cerebral spinal fluid from your ears, from your nose. So the halo sign is something to keep in mind. The halo. You don't get directly. I don't believe you get directly tested on this, if I'm being honest. But it does. I do remember it coming up on Kaplan, and it comes up on not NCLEX, sorry, your UWorld if you do UWorld, which I did, and it was good. I liked it, but the NCLEX was very surface level. All right, that's as much as you need to know for this. And you do have your study guide. I definitely recommend looking through that study guide for stuff. But again, the focus is going to be more on this ICP, CPP shenanigans and how are we manipulating it, what we're going to titrate, what medications, what interventions we're doing, how to detect stroke, how to assess this Glasgow coma scale, because allegedly you will do this. Um, yeah, it's less so much on do you know cranial nerve 3? No, or do you know parietal lobe? It's not as much about that. I would say this is actually my favorite part of this chapter is actually um, the CPP thing because I think it's really interesting how you can manipulate it. And I think when I was doing practice questions, that was the most interesting thing was having to think about how what you're gonna do to make those changes. So I think that was interesting. But again, remember surface level until you start working on a ICU neuro floor or something, or just ICU trauma ICU or something. Just keep it surface level. But yeah, let's talk about the care of the neuro patients. We're always going to start with least invasive. You should. Again, I think it's kind of like when you're bridging your O2. It's least invasive unless you feel like the deterioration is so bad that you kind of have to skip a step. Like if someone's decompensating, you try your least invasive, but if it's not working, you use your critical thinking to say, okay, from this presentation, we're just gonna go non-rebreather and kind of see where that goes from there. And kind of like when we were talking about your ABGs, you're not gonna wait for the ABG. You use your critical thinking to be like, based on what I've been looking at, I'm gonna need to ambubag this guy while we get the doctor to intubate. So kind of that same idea kind of applies, I think. Yeah, that too. The permissive hypertension. Yeah, so yeah, so if you recall your just kind of to piggyback off that, CPP is equal to MAP minus ICP. So if you have the purpose of permissive hypertension is to increase your MAP. That way you have more to subtract from, and therefore you can maintain a proper CPP. Or alternatively, we can again drain cerebral spinal fluid, and that's draining the cerebral spinal fluid will decrease the ICP, so we're subtracting less, which will also maintain a CPP that is where you want it to be. All right. So when it comes to care, you guys talked a lot about this already. So I think we'll bring a lot of the concepts that you guys have mentioned up here, and then we'll see if we can fill out other stuff here. So based off this thing here, we kind of talked about I'll actually copy paste all this, and then let's kind of repeat some of the things that you would do for the care of the patient. But then here you can have it as reference because things we already, well, that's kind of a lot. So maybe I'll make the font a little bit smaller. So let's maybe even smaller. The idea I'm getting at is just you guys can voice some things that you see here that you're like, yes, I want to do that, or that's hopefully you can see that. So we talked about things that can increase ICP. So how do we prevent these things from happening? Or I guess these are the signs, so you don't need those for this. Or we said these are some of the interventions. So yes, I want to do that, or I want to do this. Like, what is the overall concept? Positioning. Okay, let me see what we got here because you guys mentioned a lot. Ba, 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 ba. So okay, let's kind of, I'm trying to catch up on the chat. Side note, if you got cerebral edema from fusing something with glue, just drop mantle will help with that. It should, yeah. The treatment for that would be to decrease your insulin and give some D50. I'm not sure if it's D50 exactly, but you give a little bit of sugar and decrease the insulin. That I think that was actually a question I had down. That was kind of like the process. And but the mannitol can help, but the idea would be a little bit of sugar to try to fix the osmolarity of it, and then decrease the insulin infusing to try to decrease the shift. Um, yeah, so I will, or should I write it here? I'll write it here. So I'll do full screen here. So we'll go here. Boom. And the things we want to do. So here's the things we want to do. We want to do positioning. Am I writing in the right place? There we go. Positioning. Positioning. We already mentioned the head of bed. Trying to keep it below 30 to 35. I think on the U World, I remember it being like less than 30, less than 30. Log roll, decrease swell. Basically, yeah. So a lot of it is to, sorry, I'm still catching up to the chat. Avoid flexion, yeah. So a lot of positioning here. So we will do this. I know it's kind of confusing for now, but keep the head of the bed below 30. Yeah, the screen's a little small. Okay, let's try this. Is this visible, a bit more visible? I'm trying to keep this in still visible so we can reference it and then still right here. But I think, I mean, I've seen different values. I think the UWorld, yeah. I've seen like UWorld, they want it like less than 30. I think with the note, let me see what he put exactly, what the white man said. He said 30 to 45, so we'll go with that. Yeah, oh yeah, I had well actually no, we had Brooks, but I don't know. He does most of the lecture, so I just assume it was Mr. Robbins. He did substitute for Brooks when we were doing our case study. That's probably what I'm thinking about. Ooh, I'm lagging. Oh, there's like a black box there. Let me fix that. Ah, damn. Kaylin calling it the auditory meatus, like the first semester students telling their patient they're gonna put the Foley in the urinary meatus. And please, ma'am, can you put your legs in dorsal recumbent position? And they're like, what in the world is that? Not the acute angina. I think we got off track. Sorry. what were we doing? Yeah, positioning, prevent hip flexion. Yeah, so you mentioned that. What else we got? Trying to keep up with chat. No Trendelenburg, we mentioned that. Yeah, try to keep everything. Get the midline to JB draining. And no Trendelenburg, no drastic motions. That's the right color. I think it just looks weird because of that. We'll do this. Why'd you put side note? Side note? Okay, she has a question for you guys while I catch up on the chat. Said no Trendelenburg. All right, what else can we do other than positioning that potentially is listed over here somewhere? Calm environment. I like that. So decrease stimuli. We did. It's just kind of like previously, so I kind of wanted to stool softeners. We said Sofran, pain management. I think it's probably easier if if we just talk about the things we already mentioned. We'll just do this. Keep it simple. Yeah, no straining. Good morning. Good morning, Miss Julie. Antihypertensives. I would say, yeah, it probably depends on like how we're managing it because there is permissive hypertension. So like, yeah, there's usually a goal for your blood pressure. So it depends where you want it to be. So I would say manage BP, whether up or down. Yeah. Anything else that we talked about that could be good? I'll include ABCs because that's pretty obvious. So we'll just keep that in there. ABCs, we say intubate if if GSC less than 8, intubate. We talked about. I'll write some of the stuff you guys already talked about. So hyperventilate to decrease CO2. I like that. Seizure precautions, because what's more stressful than a seizure? I mean, you're gonna try to do your best to like prevent it. Wait, what? Capra. Sensory input. So seizure precautions. Again, that's suction and O2 at bedside, padded side rails, anticonvulsants, which depends on whatever they need. Yeah, the Keppra. You said Colace, antiemetic, Sofran to limit ICP straining, pain management, sedatives depending if needed. Okay. Yeah. So potentially if needed, sedation, PPIs. I'm definitely not against it to prevent stress ulcers or something. Yeah, temperature control. So there can be different you can you can have like a neurological fever kind of thing. Cooling measures. Yeah. Yeah, you can also have hypothermia. If I recall, neurogenic shock has hypothermia. Like it needs to be you need to be heated up, but then for neurological fever, you need the cooling measures. That's pretty much what you got here. You said hyperventilate. Let's just add oxygenation. Or it's ABC, so we'll just put that in here. I know you guys know that. Okay, so then I have just general diagnostics. They listed like some general things. I just kind of simplified it to baseline labs. You're not really gonna be directly tested on like which specific. It's pretty much you get your baseline and call it a day. I think I do have something here like transferred to let me see. Transferred to imaging within 25 minutes of a traumatic brain injury. Just go with that. But yeah, yeah. I didn't really write any of it down just because it's just get the baseline and call it a day, but I'll include it. So playlist PTINR, PTT. I think he said toxicology and stuff. ABGs. Okay. Okay. And then we mentioned that. Then we have like general interventions. So what are some things, I guess, here? Kind of already talked a lot about that, to be honest, like over here. So I guess we already did that. It'd be more like the medication. So just purely like medication based. So we said, yeah, we talked about medical toxicology, yeah, for here too. But again, you're not going to be directly tested on that. So I didn't really put emphasis on it as much. Um, we said mannitol a few times. We said 3% NS a few times. So propofol for sedation, yeah. Propofol for sedation. Someone said fent. I think someone sedate me. Yeah, it's a balancing act. Fentanyl, yeah. Anyone else? So antihypertensive, yeah. So you can have vasopressors, you can have beta blockers. Depends on what you need. There's an important one. Yeah, Nimotop. MO top is there to prevent. What is it there for? This is a calcium channel blocker. We mentioned beta. There's some beta blockers, just general antihypertensive. So again, keep the SBP, just say between 120 and 180, according to Brooks. Keep MAP consistent. Yeah, prevent decrease vasospasms. Cool. So decrease vasospasms, which in turn decreases ICP. There's nitrite, yeah, nipride. I think that's nitroprusside, yeah. Powerful vasodilator. So again, you see that there's vasodilators, and then there's also vasopressors, because the whole point is just to keep the MAP consistent at whatever goal you're at. So again, you're seeing things that, decrease blood pressure, and then you also see vasopressors, because the goal is just to kind of keep titrating until you get where you want. It's not as black and white as some other things. Yeah, steroids. So IV steroids. So for example, actually, no, he doesn't give an example, but you would probably expect like Solumedrol, IV Solumedrol or something. Yeah. So if you have swelling, we talked about how all that, when you have really bad hypertension, that can build up pressure. There's swelling. So if you want to decrease swelling, you use your IV IV steroids for it. So decrease swelling in the brain. The only thing to keep in mind is, monitor hyperglycemia. That's always going to be something you think about with IV steroids, hyperglycemia, especially because hyperglycemia can have an effect on your fluid shift stuff, can have an effect on certain things. So it's like a careful management. This is why the ICU gets two patients and why they're titrating a whole bunch of stuff, because there's a lot of stuff to think about. You can do this for this purpose, and then you have to watch out for this. You do this for this purpose, and then you have to titrate this, and then you have to stop that one at some point because you went too far, and then you have to maybe start something else to decrease, and then that goes too far, and then you do the other one again, then you're doing this. Yeah. Um, But let's talk about mannitol. I think that's the one that they're more focused on. So we said it's used through decreased swelling, and it's got a rapid onset. Yeah, this is the big one that you really should know. 100%. You can expect to be tested on it. The Mac Daddy. Is that how you're the Mac Daddy? Yeah, this is the diuretic. It works in a sort of like diuretic-like effect. So it's going to affect your kidneys. And or at the very least, you're gonna want to make sure that you're able to have functional kidneys, because otherwise it's not gonna do the work. I don't think you need to know how fast it works, but 10 to 15 minutes. It's very rapid. So if you're wondering what you're using mannitol versus 3% normal saline, your mannitol's rapid onset. So it's used for rapid ICP reduction. While your 3% is used for more long-term, slow chronic reduction. So it's not as fast, but it's something to monitor. So, but they're used to do the same thing. Yeah. So she's been in the ICU for her preceptorship, so she's probably seen a lot of stuff. But yeah, we talked about this. So I'll post it. If the patient is not able to pee, that's what that means. Anuric, they're not able to pee or has significant renal impairment, then we're not going to give it, because they need to be able to pee the fluid after it's been shifted into the intravascular. I don't think I don't think you'd get canceled before I do after my comments. Today was funny. So what are some things that you want to monitor with mannitol? We talked about kidney function, so we're gonna do like a BMP to monitor basically your BUN, creatinine, electrolyte, essentially. Sure, urine output. Okay, yeah. How do we get some good eyes and nose on a patient that's you probably wanna have a Foley catheter? I'll type it out. Foley catheter to monitor strict eyes and nose. Cool. The osmolarity of the serum. I don't really see too much of that often. Like ordered. I think I've seen it one time. I think they usually just go off signs, symptoms, and like some other labs, like urine output and stuff. Yeah, I like that infiltration, extravasation. So this one has a risk of extravasation. Do I know what the antidote is? Let's see if there, I'm sure this, let's see, mannitol antidote or whatever. Like if extravasated, is that the word? I guess that's the one. You don't need to know it, but I was just curious. Yeah, if you can do that, then be even better. So you want to use a large bore or a central line. So probably best if used in a central line or large bore IV due to risk of extravasation. Yeah, predisposed to CHF, currently being used in this context. See what being used, Kalen? Oh, yeah, I see what you're saying. Like in this context. Yeah. So with these patients, you're also assessing that. Yeah, lung sounds and stuff because it can because essentially this is going to be pulling things into the intravascular, and then your body is supposed to be like, oh, that's not supposed to be there. Let's pee it out. But if you have issues with a lot of fluid being in the intravascular, so CHF people, they have difficulty pumping, and if you increase their intravascular, they're not gonna, their hearts aren't gonna know what to do with it, so it will migrate to the lungs due to pressure. Or if their kidneys aren't working, then it gets kind of stuck in there, and like again, it can go to the lungs. So the main idea is if they're not able to pee it out, or if they have issues with CHF, chronic kidney disease, this one can cause them to get pulmonary edema. So assessing the lungs is good. It's gonna be your main thing. Something that I know you guys would click if this was a choice, and we kind of talked about it in like when we had questions last week, which was I think we had one where it was which ones would be a sign that this treatment isn't working. I think this was for decay. So like the purpose is this patient has a low GSC and their GSC was not improving. So we knew that that was a possible that was like a sign that the treatment wasn't effective. So the purpose of this is to decrease ICP. So the GSC should also be improving and the level of consciousness should also be improving. So that's something for you to assess to see, that's part of the nursing process. So you do something, you see if it works after. So yeah, you're at pi. That's for the most part. I think your key points though is this part. That's your key point. Just know that it's rapid. That's probably a key point. Some of the other things here is probably key points, and this makes sense. I think this is a key point as well. Knowing that it affects the kidneys will kind of make it more obvious that these are answers. And for the lungs, just kind of remember it brings all the fluid. It tries to decrease the swelling by bringing the fluid intravascular so you can pee it out. But if you're not able to manage that properly, if you're not able to manage it properly, then it can go into the lungs. So then 3% normal saline, decreased cellular swelling again, but this one's more long term. It's gonna have practically the same stuff. And according to this one you hold specifically of the osmolarity is a certain amount, but again, I don't see it too often, but I've also never been in the ICU because of I think it actually wasn't West Coast, it was a different private school that took all our spots. But yeah. And the nurses were complaining about them too. They were like, one of the nurses was like, I don't want to work with no students because they thought we were from West Coast initially. And so she was like, I'm not taking any students. And then I think she saw my badge. Oh, not the badge, the little thing on the side of the top uniform, the patch. Yeah, the patch. And then she asked my nurse, like, wait, they're not from West Coast? They're like, no. It's like, okay, never mind. We'll take you. And then I heard my nurse was like last week or something, or even I think yesterday, there was like, they got assigned like West Coast students and like they like just disappeared. I think they were hiding. And I'm like, what's the point? Like, what's the point? So she's like, I am working with them. I'm like, fair. Because I think that I would get annoying if you were like, okay, you have a student assigned to you and they're not even trying to, they're not even trying to do anything. Uh, yeah, and then I don't know. I feel like that would get annoying. I know. It's so sad. Yeah, but yeah, we make fun of West Coast around here. If I had one of the cat be hiding in my house. Oh, I have a story. In 212, we had a night shift nurse that graduated from West Coast. We saw in the chart that the patient's diuretic was like 6 hours late. She forgot to give it, and then she was trying to go home. She told us that she would give the diuretic before she left. She left without giving it. So, so that diuretic was like 7 or 8 hours late. I think it was like an IV Lasix on a CHF patient. I think it must have been, yeah. She she's just like, oh no, I'll do it before I leave, and then she left anyway. Eh, yeah, I guess so. I see what you're saying. I see what you're saying. What? What did they prep her for then? If it wasn't for the NCLEX, I thought West Coast. Honestly, I thought West Coast was like you paid 150 to pass the NCLEX, and then you kind of just fuck around in the clinical. I do recall seeing their numbers are ass though. Like they had like a 70% pass rate or something. Damn. All you need to know is chemotherapy, radiation, surgery. No pets, no flowers. She's still pat. Yeah, they made the new Gen NCLEX too easy, bro. I don't know. It's funny. Anyways, I think we filled this out pretty good. The 3% is pretty much almost all the same stuff. Pretty much exactly. It's just that the use case. This one's fast. This one's slower, but that doesn't mean you don't think about it. You still think about it. It's just a bit slower. Um, and still lung sounds are important. So still important for you to do that. Bruh. Okay. Well, I'm in debt, but I'm not in that much debt, so I'll take it as a win. Is acetaminophen like mannitol but slower acting? I feel like I looked this up before. Let me see. Let's I wrote, here's what I wrote. I'll just copy paste because it's pretty much the same stuff-ish. It's used for same idea, but it's used for long term and it's also more mild. So it's still short, it's still long term, like 3%, but it's also not for as bad. I think 3% is more with these two you have to monitor really hard. With this one, it's still have to monitor, but it's not as bad. It doesn't cause as much damage. If you're like not looking at it, it's not as quick. It's not as quick to work and it's not as effective. So, which means that you have a more wiggle room to mess with it or not or like to not look at it as much. I would say your Nemo top. I know that comes up a lot. I've seen Nemo top a few times on UWorld. IV steroids, just kind of getting your brain IV steroids or just steroids equals decreased swelling, hyperglycemia, and you'll go a long way. Keeping the map consistent is like the main key thing with all these. We talked about a lot of the Sofran antiemetics for all that other stuff, so I know that you guys got that down. Cushing's triad. No, I don't think I did, so let's go over that. Yeah, so let's talk about Cushing's triad. Good catch. So, yeah, you guys kind of got that down. Cushing's triad, severe ICP, increase SBP with widened pulse pressure, irregular respirations, bradycardia. So you're seeing kind of slow heart rate and increased blood pressure. So the idea is your blood pressure is so high, your heart essentially quote unquote compensates for it by beating less fast and you have weird respirations. 1-800 is the big bad. The Cheney Stokes, yeah. I think there's the only other stuff. Kalen, do you remember if meningitis came up? Because I know that's because we with this there is like a risk of infection when you're dealing with like an EVD and stuff. But do you remember if they went detailed into meningitis? Well, kind of just. So I'd say you should know that, yeah. You should know that. EVD actually didn't come up much. I don't recall. I think just knowing it exists is good. Yeah, if you see cloudy, that there's also like a glucose check. You can do a lumbar tap and see the glucose and protein levels, and that can be a sign of viral versus bacterial meningitis. Your goal is going to be your antibiotics. Usually your viral meningitis doesn't need antivirals. It's usually self-limiting. I think if it gets caught early, you can give antivirals, but otherwise you kind of just let it happen. With your bacterial, though, you need antibiotics. And the only critical thing to know, the main like one critical thing is that The way the meningococcal bacteria is, it's kind of like if it gets killed, it kind of leaves behind, I think it's like toxins that cause damage. So you have like a weird thing where you're not going to get better without antibiotics with the bacterial. Um, but with the antibiotics will in the short term actually make you feel worse because those bacterias drop a little present after they die. It gets kind of crazy. The ampicillin. Ooh, actually, I don't know the specific name for the meningitis stuff. Yeah, we talked about. Um, Again, I don't think you need high detail on meningitis, but I think with this you should have all you need here. So post-op complications, meningitis, a lot of these increased ICP symptoms, headache, altered level of consciousness, difficulty handling light, difficulty handling noises, the nuchal rigidity, so a stiff neck, that's important. The high fever. This one's like kind of specific, just like how to tell apart bacterial versus viral. So like a lumbar puncture to see the protein and glucose levels in it. A key thing is that it's droplet precaution. Droplet. And your treatment is we set antibiotics, if bacterial, IV fluids, steroids. You do use mannitol and anticonvulsants because this can cause seizures. Um, because of the potential brain damage, you can have SIADH and diabetes insipidus. So it's the same stuff you guys learned before. We talked about Cushing's triad. And the recovery is pretty basic, just like all of those neuro abnormalities we talked about in the past, just seeing how they changed and if they improved or not. I'll include all this just because why not? I don't think it's really again, this is with usual with your finals, they're a bit more surface level. This is kind of specific, but I do have it listed if you're interested. Yeah, yeah, so kind of going back in here, I would say maybe you need to know meningitis. I don't recall it. Do you recall if it came up, Kalen? Meningitis. Yeah, I don't specifically recall it. Maybe just know the signs. I would say so. But you see a lot. I'd say the key thing is this. Everything else you can kind of attribute to ICP. Brudzinski's sign. I don't even think you need to know that, but I'll include it. This picture, it has Koenig sign, Brudzinski sign. So moving the neck up causes the hips to flex. This one is leg up and up like that. So like this and then up causes pain. Did we talk about the cerebret? I don't think we did. Let me go back and talk about that. I think I skipped a few things here. We talked about GSC, NIH stroke scale. Your first sign is going to be your level of consciousness. Cheney-Stokes, blood sugar, pupillary relaxation. The doll eyes. Honestly, doll eyes was like extra information, but sorry, I was a little disorganized. I think we were both a little busy today. So decorticate versus decerebrate core. I like this one because it has the toes pointing out. It has the arms to the core. So that's how you know it's decorticate. E for extended, yeah. So E for extensors. So it's extending out. And which one's worse? Yeah. Yeah, decerebrate is worse. E for end. I like that. E for the end. I like it. I like it. I like that too. There's the doll's eyes thing, but it didn't really come up. Maybe for the U world. The main idea of doll's eyes is it's a normal reflex. So this is what normal is. So this is normal. So if someone's unconscious and they have their eyes open, and you open their eyes up and you move them to the left, their eyes should automatically stay looking at you, like forward. And if you turn them the other way, it should come back looking at you. It's bad if you turn them to one direction and their eyes stay looking that way, for example. Yeah, the eyes should be kind of rotating towards the center still. But again, I don't think it really came up much. Other things that we talk about, temperature regulation, sedation, talked about ABC's airway, Cheney-Stokes, grunting, straining, ABCs. We also have the other ABCs, so the mini mental assessment, affect, behavior, cognition. Not as it's something. There's Sarah, yeah. I think it's three. Cranial nerve three. Let me see. Whatever oculomotor is. Let's see. Three, yeah. What else do we got? We said Cushing's triad, so that's again important. So let's actually look back from the beginning and go over what I think is the most important stuff. Definitely know your CPP, your formula for it, what's normal, what's abnormal. Um, ma- Make sure you get an understanding. So this is the amount of blood to your brain, which is good. You want that. You don't want too little, you don't want too much, you want it within this range. And know your formula. So your MAP, we know that formula, we know what's normal. ICP, we know some of the things that can cause it to go up. We should know what's normal. Uh, that's uh, and some of the signs and symptoms of increased ICP, and you guys gave some examples of things that we can do to adjust and manipulate the CPP. A review of the stroke, so you need to know be fast. Basics, it's always ABCs. You should know that your CT head is very important. You should know the CT head is very important, and yeah, it's my nephew. And how fast it should be done and interpreted. The Glasgow Coma scale, you kind of should know it, even without the scale, allegedly. Again, for reference, possible causes of stroke, kind of what goes down. So you have swelling, increased ICP. If you have increased ICP based on your formula, you have more being subtracted from the MAP, which means you have a lower CPP, which is not good. This is the extra information. your TBIs, kind of some of the general idea of what does it mean to have altered neuro, examples of things that can cause that. If less than, if your GSC is less than 8, you got to intubate. The things we talked about before, your positioning is important. Pain management, reduce stimulation, reduce straining, hyperventilation to decrease CO2. Um, CO2 is a vasodilator which will cause an increase in ACP. So we hyperventilate. If needed, sedation, so propofol, temperature regulation. If they're having a neurological fever, we can do cooling measures. Uh, and then on the opposite end, if they're having like a neurogenic shock, then you actually need to have them at a higher, like a, you need to keep them at a different temperature. So one, it's different from the neurological fever, but I don't think that's important. It's just there to differentiate because we had neurogenic shock in the past, so just to not get confused on that. Decorticate versus decerebrate, so we know the difference. We know decerebrate is worse because E for extension, E for the end of your life, I guess. That's a good one. I really like that one actually. The doll's eyes, so your eyes should be um whenever they move, their head gets moved, the eye should still face towards the center. We talked about some baseline labs. Again, know your mannitol. Know that it's for rapid. Know that if the kidneys aren't working, then the mannitol is no go, and that it can cause edema, a pulmonary edema. Same thing with 3% pulmonary edema. For Diamox, same thing, pulmonary edema. So just kind of get that in the brain. Nimotop for the vasospasms. You mentioned the sedation, pain management, steroids for swelling, and kind of just remember that you have that game essentially where you're playing with vasodilators, beta blockers, vasopressors to try to get that MAP where you want it to be. So it's not just, oh, yes, you're always vasodilating or you're always vasopressing. It's whatever makes sense, whatever, and you'll probably be titrating them, running two at the same time. Stuff, weird stuff, right? This is key, your Cushing's triad, to know when things are going down. So maybe if you have like a prioritization question, which ones needs take priority? The person with these symptoms would be someone having severe ICP. You don't need to know too much about the EVD. Just know it's a way for you to drain cerebral spinal fluid and therefore decrease the ICP. And because it's a external thing, it can lead to infections, and your infection main thing is your meningitis. It can also cause encephalitis, but I think meningitis is the more common thing because I think it's in that layer where the meninges are. Uh, yeah, again, here are your key signs and symptoms, mostly just ICP related things, and nuchal rigidity is like a meningital specific thing. Your key things is droplet precaution, and antibiotics, if it's a bacterial, is key, as well as some of your other stuff here. Decrease ICP, prevent seizures. So kind of all ties back to your ICP management. Steroids just like ICP management. But it's an infection, so we're also gonna do some IV fluids to make sure that we're doing okay. And again, some extra information. When you have brain damage, and brain trauma, you can have DI or SIADH happen because the little things, the little hypothalamus and pituitary gland, whatever releases a lot of that stuff's in your head. So these are some things that can occur. But that's just review from I don't know if this was 232. It might have been. I don't even think it comes up, honestly. I think it was just briefly mentioned, but again, just focus on your main material. This material is not going to make up the majority. The majority is still going to be like the comprehensive. But again, as with all the finals, it's a little bit more surface level. But again, that doesn't mean don't study, and that doesn't mean it's going to be easy. It's just not gonna require you to absolutely know the absolute hyper detail. It'll still make you think. You'll still have to critically think. You'll still have to know your stuff. It's just you won't have to have like doctor knowledge on the stuff like you might on some of the other tests where they test you on. Yeah. You got an extra point. What for? Was the pod look that good? Damn. Wait, what'd you actually what'd you guys get an extra credit point? What? Oh, you're right. What do you mean? I brought you the pops. The watermelon pops, popsicle things. What question? Oh yeah. Interesting. Oh, I'm gonna end the recording for now.